Good morning. I'm Dr. Sherilyn Santiago Salimo, medical oncologist, and I will discuss with you the second part of Principles of Cancer Management. I will discuss about the management of disease and treatment complications and supportive care as well. Remember that cancer therapies are toxic, so we need to address the complications, whether it is secondary to the cancer itself, secondary to treatment, or secondary to psychosocial problems. Complications secondary to cancer involves problems secondary to the tumor itself. Treatment, it is related to what we are going to give to the patient, whether chemotherapy, hormonal, or targeted therapy, or with other treatment modalities as well, such as radiation side effects and possible long-term side effects in terms of surgical management. For the psychosocial problem, we should also focus on illness-related distress, whether psychosocial, spiritual, or existential needs. Concerns regarding social support and resources like home, family, and financial issues must also be addressed. Remember, to be specific, remember that in treatment-induced toxicity is less acceptable if the goal is palliation. Going back to the first part of the principles of cancer management, we have learned that what are the two goals of cancer treatment. So one is curative intent and one is palliative intent. The goal is palliative if we are going to give that treatment to patients who are already in the advanced stage or what we call stage 4 cancers. And in this group of patients, the goal of palliative treatment is to improve the quality of life. So because of that principle, when giving treatment to the patient, regardless of what it is, the goal is to, as much as possible, get the efficacy of that medication, but at the same time, provide less toxicity so that the patient can be able to more or less do regular activities or more or less be more functional. Most common side effects of treatment is nausea and vomiting, as well as myelosuppression, including neutropenia, anemia, and thrombocytopenia. These side effects and the management will be further discussed later under supportive care. So let's discuss first depression. So this is expected in majority of the cancer patients. Why? The diagnosis or the more or less the acceptance of the bad news itself, meaning the doctor telling the patient that he or she has cancer and at the same time dealing with treatment and its side effects. Combination of these two would really would really contribute to a high incidence of depression. So more or less, based on the studies, the incidence of depression in cancer patients is 25% overall. So the diagnosis is likely in a patient with depressed mood, dysphoria, and or loss of interest in pleasure, anhedonia, for at least 2 weeks. So please take note of the following symptoms in this slide. If your patient will present with 3 or more of the following symptoms that are sustained, meaning it lasted for at least 2 weeks or more, then the likelihood of the diagnosis of depression is more likely. In these types of patient, they should receive therapy. And upon giving medications or medical therapy, we should allow at least 4 to 6 weeks to see a response. So example of the medications that are usually given include serotonin reuptake inhibitors like fluoxetine, sertraline, paroxetine, tricyclic antidepressants such as amitriptyline and desipramine. Effective therapy should be continued at least 6 months, even after the resolution of symptoms. We have other methods as well, such as psychosocial interventions like support groups, psychosocial therapy, and guided imagery. So remember that in the approach of treatment of cancer, it will always be a multidisciplinary approach. So we need to refer the patients to various subspecialties if needed, and it will depend upon early recognition of that problem. So in the case of depression, it is really advisable for the patient to be referred to a psychiatrist for more or less support, psychologically and medically speaking, during and even after the cancer treatment. Long-term follow-up. So usually at the completion of treatment, sites originally involved with tumors are reassessed, usually by radiography or imaging techniques, and any persistent abnormality is biopsy. If the patient persists, if the disease persists, the multidisciplinary team discusses a new salvage treatment. And if the patient has been rendered disease-free by the original treatment, the patient is followed up regularly for disease recurrence. So always remember that as time passes, the likelihood of recurrence of primary cancer diminishes. And for many types of cancer, survival for 5 years without recurrence is tantamount to cure. So during the surveillance, more or less, we will see that in the guidelines during the first year of surveillance, the monitoring or the imaging studies, the consultations, the physical examination is more frequent, usually close to every 3 months at least. And then, as you can see, as the years go by, the surveillance or the follow-up usually more or less decreases. So from every 3 months, it will go to every 6 months on the second year, every year on the second year, on the third year, and so on. So this is more or less compatible with what was explained in this slide. As the time passes, the likelihood of recurrence of that primary cancer usually diminishes. What are the some late complications of cancer therapy that we should expect? So actually, it will depend on what type of cancer it is. It depends on the multidisciplinary approach or treatment that was given to the patient. For example, uh, this first slide shows various surgical procedures. Number one, amputation. Probably common in patients diagnosed with sarcoma or bone cancer. So, of course, we are expecting functional loss depending on what part of the body was involved. Lymph node dissection. This is very common in breast cancer patients, especially those who receive definitive surgery or modified radical mastectomy. So in this procedure, lymph node dissection is expected, and there's a risk of lymph edema or swelling of the arm on the same side of that procedure. Ostomy, splenectomy, adhesions, bowel anastomosis. Adhesions, secondary to any surgical management, specifically of the abdomen. Bowel anastomosis usually done in cancer and in colon and rectal cancer, wherein they will do hemicolectomy, abdominoperineal resection, and so on. Next, among the multidisciplinary treatment that we can expect late complications, radiation therapy. So again, it will depend on the part wherein radiation is administered. So for brain cancer, we give whole brain radiation therapy. For the bone, as part of palliation for bone pain in patients with bone metastases, more or less, in some organs like the heart, for example, in breast cancer patients who will receive adjuvant radiation therapy, and more or less the location of the breast involved is specifically on the left side, then of course we should also watch out for any side effects, such as pericarditis, myocarditis, or coronary artery disease. Okay, for chemotherapy, actually, these are just some of the examples. In reality, there is more than this slide, but let me pick some of the examples. So, for example, in breast cancer patients, especially those who will receive adjuvant chemotherapy, anthracycline based chemotherapy is very common. So prior to more or less giving this drug, we usually do 2D echo with Doppler so that we can evaluate the function and the strength of the heart prior to the administration of drug. Trastuzumab is given in breast cancer patients with HER2 new positive breast panel result. And same with anthracycline, we need to do a baseline 2D echo with Doppler in order to monitor um, the function of the heart while giving this type of drug. And in trastuzumab, we continuously monitor using 2D echo every 3 months until the treatment is done, which is usually up to 1 year. For example, if you are going to give bleomycin, which is commonly given in testicular carcinoma, then because you know that the possible expected side effect is pulmonary fibrosis, then you should do a baseline pulmonary function test in order to be sure if the patient have already some problem in the lungs prior to the treatment, so that more or less um, we will be secured that the organ is functioning well prior to the administration of the drug. Alkylating agents and others. So most of the chemotherapy agents can cause infertility and premature menopause. So especially if your patient, whether a male or a female, is under the reproductive age group, it is very important to explain first um, the possible side effects of the treatment that they are going to receive. But luckily, because more or less we are already in the advanced um, age or era, especially for the females, there are already some options wherein the patient can have their eggs stored, or even preservation of ovarian tissue, and for the males, of course, sperm preservation more or less prior to the treatment, so that more or less if they would really experience infertility later on in their life, at least they have a backup plan. Let's proceed with supportive care during cancer treatment. So always remember, in oncology, to cure sometimes, to extend life often, and to comfort always. The success of cancer therapy depends on the success of supportive care. So remember that supportive care is the major determinant of the quality of life. World Health Organization defines quality of life as an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. It is a broad ranging concept affected in a complex way by the person's physical health, psychological health, personal beliefs, social relationship, and their relationship to salient features of their government, of their environment. So, number one, under supportive care would be pain. Especially in patients in the advanced stage of cancer, we usually encounter this one. So pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in relation to such damage. So 25 to 50% of patients present with pain at diagnosis, 33% have pain associated with treatment, and 75% have pain with progressive disease. 70% of the cases is caused by the tumor, 20% secondary to a surgical or a medical procedure, or probably secondary to radiation or chemotherapy injury. And 10% of the and in 10% of the cases, pain is unrelated to cancer or its treatment. So what are the goals of pain management? So we have 5 A's of outcome. So analgesia. So of course, when we give medication, our goal is more or less to relieve the patient of the pain as much as we can. So in terms of activities, so optimize activities of daily living. So once the pain is controlled, everything will follow. If the patient is in pain, definitely the patient won't be able to sleep well, won't be able to do anything, won't be able to eat, and the patient will be continuously anxious and more so be depressed. So it is very important that they are satisfied with what they are feeling so that they can go on with their more or less daily activities. Number 3, when we give pain medications, of course, we should minimize adverse effects. I think the most common example would be the opioids. Always remember that when we give opioids to our patient, you should call their attention that the more or less most common expected side effect would be constipation. So in preparation for these side effects, again, we need to anticipate and treat prophylactically with a stimulating laxative to increase bowel motility as indicated. You can even advise the patient in terms of diet, what would be the fruits or specific foods that may more or less lessen the chance of constipation as well. uh, we need to avoid aberrant drug taking, meaning the goal is to set the dose and frequency wherein the patient can more or less achieve the appropriate pain relief that the patient wants. So we need regular schedule and more or less a consistent dose. If the patient is not satisfied in terms of analgesia, definitely there is a chance of the patient taking medications irregularly or increasing the dose um, irregularly without telling the doctor and so on, just to more or less relieve the feeling of pain. So we should avoid more or less that scenario. And of course, lastly, the affect relationship between pain and mood. So of course, definitely, if the patient is in pain, then more or less everything will follow. The patient will be anxious and will probably be in a depressed mood. The coordination also with the doctor in terms of the treatment will be very difficult, especially if the patient is in pain. So these are the 5 A's or goals that we want in pain management. So routinely screen for pain. So in all cancer patients, actually not only those in the advanced stage, patients in the early stage of cancer may also experience pain. From where? If the patient underwent a surgical procedure or more or less a side effect of the drugs being given to the patient. So irregardless of the stage of cancer, we should always screen for pain during consult. And if the patient more or less told you of a specific pain, then extract further. As we have learned in our physical diagnosis, you should extract the PQRST. Okay, so we should check for pain experience, etiology, pathophysiology, specific cancer pain syndrome, patient-specific goals for comfort and function, risk of substance use disorder. So if it is not related to an oncologic emergency, you should check also for opioid naive versus opioid tolerant patients. If related to an oncologic emergency, analgesics plus treat the underlying cause. Oncologic emergencies will be discussed separately, but under oncologic emergency, we have um, your superior vena cava syndrome, you have your spinal cord compression, you have your hypercalcemia of malignancy, tumor lysis syndrome. So more or less, in oncologic emergency, well, one, supportive treatment by using analgesics and at the same time, treat the underlying cause. During screening, some would say no pain, or some would say of an anticipated painful event. How do we rate our, how do we do pain intensity rating? So again, assessment of pain is based on the history of pain, its location, character, temporal features, provocative and palliative factors, and intensity. So what are the tools for assessing pain? So we have the numerical rating scale, under which we have to either verbal or written. So for the verbal, you just say, what number describes your pain from 0, no pain, to 10, worst pain you can imagine? So for written, you just give the patient the number 0 to 10, label it 0 as no pain and 10 as worst pain you can imagine, and then just ask the patient to circle the number that describes your pain. So another way would be categorical scale. For the categorical scale, you usually ask the patient, what word best describes your pain? None, or is it mild, moderate, or severe? And another tool would be the FACES pain rating scale. So these phases more or less show how much something hurt. So this phase, for this slide, so this phase, point to the leftmost phase, shows no pain, and each phase shows more and more pain. So point to each phase from left to the right up to this one, the point on the rightmost phase, it shows very much pain. So point to the phase that shows how much you hurt right now. So that's how you ask. In short, ma'am, base po sa mga drawing na nakikita nyo ngayon, gaano po kasakit ang inyong nararamdaman? Okay, so after more or less determining the pain intensity, the next thing to do would be to give the appropriate medication depending on the level of the patient's pain. So for those with mild pain, usually the first line would be your non-opioids pain medication such as acetaminophen and NSAIDs. If the patient will not be relieved by those type of drugs, then you can give adjuvant therapies such as antidepressants or anticonvulsants. Example of antidepressants that can more or less be added to your non-opioid pain medication would be your SSRI, your SNRI, your tertiary amine, the amitriptyline, doxepin, and imipramine. So other types would be your venlafaxine, bupropion, duloxetine, more or less for support to your non-opioid pain medications. For the moderate type of pain, 4 to 7, again, you start with your non-opioids, followed by your antidepressants or anticonvulsants. Example of anticonvulsants that can be used in this case would be your pregabalin and your gabapentin. If the combination of both will still won't work, then you can add short-acting opioid as needed. For example, we have what we call Oxynorm, 5 milligram per tablet, a short-acting opioid that can serve as more or less rescue dose in between if the patient still complains of pain despite giving your non-opioids and your adjuvant therapies. For patients in severe pain, we need to advise admission to achieve patient-specific goals for comfort and function. If the pain is severe, definitely we will need a higher type of medications in various forms, whether in the form of drip, patch, oral, sublingual. But the most important thing under severe pain would be to discuss with the patient what is the goal, more or less, um, to determine how much we can go using that pain medications to relieve the pain of the patient. But always remember that especially in cancer patient, we cannot really perfectly alleviate the pain most of the time. Okay, so 85% of patients will have pain relief from the usual pharmacologic intervention as what was mentioned in the previous slide. And the other 12% of the patients will respond to other types of modalities. If the pain is caused by the tumor itself or by the cancer itself, then anti-tumor therapy would definitely help in relieving the pain. For example, if the pain, example, abdominal pain, is secondary to obstruction, a colon mass, a rectal mass, then a palliation surgery or palliative surgery would provide relief of the obstruction, hence the relief of pain. Radiation therapy is also another modality that can relieve the pain, especially in our patients with bone metastases with severe bone pains. Strontium 89 or samarium 153 treatment for bone pain would also help. If we refer to our neurologies, we have neurostimulatory techniques. For anesthesiology, we have regional analgesia, neuroablative procedures. For the regional analgesia, usually in severe pain in cancer patients, in pancreatic cancer patients. Okay, so after pain, the second, more or less, side effect that we usually see in cancer patients would be myelosuppression, and this is commonly secondary to the cancer treatment. So the common cytotoxic chemotherapeutic agents almost invariably affect bone marrow function. So titration of this effect determines the MTD of the agent on a given schedule. So MTD means the highest dose of a drug or treatment that does not cause unacceptable side effects. So the MTD is determined in clinical trials by testing increasing doses on different groups of people until the highest dose with acceptable side effects is found. So this is called the maximum tolerated dose. So the sequence and sensitivity of each of the formed elements to chemotherapy, for example, for your polymorphonuclear leukocytes, the half-life is 6 to 8 hours. For the platelet, it is 5 to 7 days. And for the RBC, it is 100 days. So maximal neutropenia occurs 6 to 14 days after conventional doses of anthracyclines, antifolates, and antimetabolites. Alkylating agents differ from each other in the timing of cytopenia. So for this specific drug, remember, nitrosoureas, your dacarbazine and procarbazine, it usually displays delayed marrow toxicity. So typically, neutropenia is expected within 6 to 14 days after the administration, but with the specific group of drugs, it usually appears 6 weeks after the administration. So we should always watch out for that. Okay, under myelosuppression, we will discuss first about neutropenia. So specifically febrile neutropenia. So in this slide, I just compared the definition of febrile neutropenia based on NCCN version 2 2020 as compared to the Harrison's 20th edition. But of course, for examination purposes, we will refer to Harrison's 20th edition. So the definition of febrile neutropenia is the clinical presentation of fever, either one episode of 38.5 or 3 readings of a temperature of more than or equals 38 but not more than, less than or equals 38.5 degrees Celsius within 24 hours in a neutropenic patient with an uncontrolled neoplasm involving the bone marrow, or more usually in a patient undergoing treatment with cytotoxic agents. Okay, so patients with neutropenia is divided into two prognostic groups. Those patients who are expected to have a short duration of neutropenia. So this group of patients will not present with evidence of hypotension or any localizing symptoms. Literally, the presentation is just the blood result of neutropenia, your WBC, multiplied by your neutrophils, plus the fever based on the criteria that was given by Harrison. So in this group of patients, we can give oral antibiotics only, such as your fluoroquinolones, specifically either your ciprofloxacin or moxifloxacin or amoxicillin plus clavulanic acid. For who are the patients on the second group, wherein these are the patients expected to have prolonged neutropenia. Prolonged neutropenia is defined as febrile neutropenia, which usually lasts more than 7 days. So these patients usually presents with evidence of sepsis and end organ compromise, particularly pneumonia. So we will discuss further the medications that should be given in patients with prolonged neutropenia. So I will discuss the second bullet after showing you this slide. Okay, so once with febrile neutropenia, especially those who are expected to have prolonged neutropenia, what would be the approach? So under initial evaluation, of course, the first thing is to look for any source of infection. For physical examination, you check every part of the body that may show any signs of infection. Skin lesions, mucous membranes, IV catheter sites, perirectal sites, and so on. At the same time, we are going to immediately request for examinations, blood culture, chest x-ray, and any other tests that may more or less support the presenting symptom of the patient, such as urinalysis, etc. So while doing that, and while waiting for the results to come, we should immediately administer a broad-spectrum antibiotics. Broad-spectrum antibiotics is defined as an antibiotic that covers both gram-positive and gram-negative aerobes. So that would be the first step while waiting for the diagnostic results to come. Once with result, there are two possible scenarios. One would be one of the diagnostic tests would show a specific source or site of infection, and the other one would show, example, all negative results, meaning no obvious infectious site. So for the left side of this slide, for those who will more or less have a specific site of infection, so as much as possible, number one, so look for the best antibiotics that would more or less target that specific infection. But it does not necessarily mean that you can more or less narrow the spectrum unnecessarily. So you still need to continue to give an antibiotics with gram-positive and gram-negative aerobes coverage. And then after that, continue the treatment until the neutropenia resolves, which is a granulocyte count of more than 500 per UN. Okay, for those with no obvious sites of infection, we should continue to observe, because remember, we are already, at this point, we are already giving your broad spectrum antibiotics. If the patient would respond, or more or less will be a febrile after a few days, then just continue the regimen until again the neutropenia resolves. But if the patient is still febrile after 7 days of broad spectrum antibiotics with no specific obvious infectious site, then you should add a broad spectrum antifungal agent. Continue both, and then again, continue the treatment until the neutropenia resolves. Okay, for the antibiotics that was mentioned earlier, the broad spectrum antibiotics that should be started immediately. So, example of the antibiotics that can be given would be your ceftazidime or cefepime. So, our third and fourth generation cephalosporins, piperacillin tazobactam, or imipenem cilastatin, or meropenem. So all three regimens have shown equal efficacy in large trials, and all three, take note, have an active coverage against Pseudomonas aeruginosa and a broad spectrum of aerobic gram-positive and gram-negative organisms. Okay. Again, I think I mentioned this already. In the absence of any originating site, so give a broad spectrum antibiotics with anti-pseudomonal coverage. If you can see other potential sources like cutaneous site of origin, remember to add vancomycin. If you are suspecting an abdominal infection or infection in areas wherein anaerobic organisms are more or less common, then you can add metronidazole, or the broad spectrum antibiotics that you can start can be imipenem. Okay. Some also have coexistence of pulmonary compromise. Potential pathogens include Legionella, pneumocystis, and fungal agents. So, G-CSF. So, febrile neutropenia, we have discussed the approach, the antibiotics required, and for the decrease in more or less the WBC count. So, what is G-CSF? So, G-CSF means granulocyte colony stimulating factor. GM-CSF means granulocyte macrophage colony stimulating factor. So, first, before we discuss this slide, what is the difference between the two? So, G-CSF is also called colony stimulating factor 3. This is a glycoprotein that stimulates bone marrow to produce granulocytes and stem cells and release them in the bloodstream. As compared with your granulocyte macrophage colony stimulating factor, this is also called the colony stimulating factor 2. This is a monomeric glycoprotein secreted by macrophages, T cells, mast cells, natural killer cells, endothelial cells, fibroblasts, that function as cytokine. More or less, this monomeric glycoprotein is a white blood cell growth factor. So it stimulates stem cells to produce granulocytes, neutrophils, eosinophils, and monocytes. It is part of the immune inflammatory cascade by which activation of a small number of macrophages can rapidly increase in their numbers to more or less provide an adequate number to support fighting for any kind of infection. So the question is, when do you give G-CSF? Let's more or less stick with that, as GM-CSF is more commonly used in hematologic malignancies such as leukemia. So when do we usually, preferably in those types of malignancies, but At the same time, they can also, both of them can be used if indicated. So what are the indications? So we have two. So preventive and therapeutic. So under preventive, we have what we call primary CSF administration, and we have what we also call secondary CSF administration. So primary CSF administration, meaning you already order or you decided to already give G-CSF on the first cycle of the patient's chemotherapy. Meaning, after giving the cycle 1 chemotherapy, you will already order it as prophylactic, more for prophylactic intent. Not needed on a routine basis, meaning not all patients who will start with cycle 1 chemotherapy should be given primary CSF administration. So there are factors that you should take note of, and if your patient will fall under one of those factors, then yes, you can give primary CSF administration. So what are those? So patients with the probability, if the probability of having febrile neutropenia in that patient is more than or equals 20%, if the patient has pre-existing neutropenia or active infection in old patients, in patients more than 65 years old, especially if treated for lymphoma with curative intent or other tumor treated by similar regimens. Those patients with poor performance status, I think performance status was already discussed on the first part. Those with extensive prior chemotherapy, meaning those patients who are already on their second line, third line, fourth line of chemotherapy, then of course you should give your primary CSF administration. For those patients in those dense regimens, especially in clinical trials, yes, we can consider that also. Dose dense regimens means small dose of that drug. For small dose, you will give a smaller dose of that drug, but with shorter frequency. For example, paclitaxel, one example of your taxanes that is usually given in breast cancer patients. So in those patients, for example, we give paclitaxel to be computed at 175 milligram per meter square and to be given every 21 days. An example of a dose-dense regimen would be, for example, paclitaxel, we will only give 80 milligram per meter squared, but we will administer it or give it more frequently, weekly, versus the other one with a higher dose wherein we are giving it every 21 days. So that's an example of your dose-dense regimen. So if one of this is present in your patient, then you can definitely give primary CSF administration. So who are the patients that should receive secondary CSF administration? These are the patients, for example, this patient, you already gave cycle 1 chemotherapy. You did not give any primary prophylaxis or CSF or G-CSF administration because the patient did not have any of the factors mentioned here. But after the repeat CBC, more or less, you've noticed that the patient had history of febrile neutropenia, meaning the WBC went down and more or less the patient become febrile, meaning based on the criteria that we have discussed later, automatically all succeeding cycles you should give G-CSF prophylaxis already. Other factors includes those with prolonged neutropenia even without fever. For example, it did not fit the criteria of febrile neutropenia, but meaning the patient presented with neutropenia but with no fever, but more or less it is really prolonged. So prolonged enough that the succeeding cycles cannot be given on time, then you need to more or less give secondary CSF administration on the succeeding cycles. Okay, I think, so for the preventive use, so you should more or less take note of the primary and secondary and the factors. For therapeutic, I think more or less a shorter explanation, there's no benefit. Meaning, when you say therapeutic, um, in patient who already experience febrile neutropenia, ongoing febrile neutropenia, um, will the patient benefit from administration of G-CSF? No evidence of benefit. That's why you cannot see this on the algorithm that was presented previously in the approach of patients with anticipated prolonged febrile neutropenia. Okay. In terms of dose and schedule, so for the G-CSF, the computation is 5 milligram per kilogram per day subcutaneous route. For GM-CSF, 250 milligram per meter squared per day, same subcutaneous route as well. Pegfilgrastim. So what is pegfilgrastim? So pegfilgrastim is the more or less the long-acting form of your G-CSF or filgrastim. So okay, for the pegfilgrastim, just one dose of 6 milligram 24-hour after chemotherapy. So the next question is, when should therapy begin and end? So you can start the prophylaxis 24 to 72 hours after chemotherapy. So let's skip the second bullet. Always remember, do not use it concurrently, meaning at the same time with chemo or RT. Meaning, if you give your chemotherapy on Monday, the earliest that you can give it is 24 hours after, or as the more or less range indicated, 24 to 72 hours after chemotherapy, not on the same day, definitely. Continue. How will you determine how many dose or how many days will you give the injection? Then continue until absolute neutrophil count is 10,000. So you can actually estimate for a number of days and then repeat the CBC and assess if it is already within the acceptable value. Okay. Under myelosuppression would be anemia. Anemia associated with chemotherapy can be managed by transfusion of packed RBCs. So, what are the indication for transfusion? If the hemoglobin falls to less than 80 grams per liter and compromise of end organ function occurs. If the patient have an underlying condition such as coronary artery disease or previous history of stroke, then there is a call for a maintenance of hemoglobin of more than 90 grams per liter. For you to more or less remember this easier, if no underlying condition, transfuse if hemoglobin is 7 and below. If with underlying condition, transfuse if hemoglobin is 8 and below. Okay, erythropoietin. So this is another way of more or less increasing the hemoglobin of the patient. But how does it actually works? So EPO or erythropoietin is an essential hormone for red blood cell production. It increases the production of WBC by targeting CFUE, pro-erythroblasts, and basophilic and erythroblasts, more or less subsets in the differentiation. So EPO has its primary effect on red cell progenitor and precursor, which are found in the bone marrow in humans by promoting their survival through protecting these cells from apoptosis or cell death. So who are the patients that can receive erythropoietin, or what is the indication for giving erythropoietin? So if for the patients who are to receive therapy for more than 2 months on a stable regimen, remember the term who are likely to require continuing transfusion, more or less you can offer erythropoietin. But remember that when you give erythropoietin, you should explain to your patient that you will not get an immediate result. As compared with your pack RBC, one pack RBC will increase your hemoglobin by 1. So plus 1 immediately. So after the transfusion, if you repeat the CBC of the patient, definitely the increase in hemoglobin will already be reflected. In erythropoietin, more or less, you need to give it time. So usually, the effect will be within months after consistent administration. So you should explain that to the patient that it will not give you a sudden rise in hemoglobin as compared with your pack RBC. That's why the indication for this one are for patients who are expected to continuously have anemia or hemoglobin below the desired level for a long time. But please take note also that some randomized clinical trials shows that giving of erythropoietin promote some tumor-related adverse events. So you should really weigh the pros and the cons in giving erythropoietin. So always remember the cutoff that was discussed from the previous slide. So remember also that the maintenance of hemoglobin of 90 to 100 is more or less acceptable already. Higher levels than that, example, 110 to 120 grams per liter, it is unclear if it is associated with improved quality of life. And for levels higher than that, like 120 grams per liter, it has been associated with increased thrombosis and mortality rates in cancer patients. Okay, last under myelosuppression. So I think the most commonly encountered abnormality under myelosuppression, especially in cancer patients that would be under treatment related, would be neutropenia. So for thrombocytopenia or decrease in platelet, meaning levels less than 100,000, it do not frequently complicate the management, with the exception of certain carboplatin-containing regimens. Thrombocytopenia is commonly encountered only in patients with certain hematologic neoplasms wherein marrow is already infiltrated by the tumor. So, severe bleeding usually occurs if the platelet count is less than 20,000 and very prevalent at counts of less than 5,000. So the precise trigger point at which when more or less to transfuse platelet would be if the patient's platelet count is less than or equals 10,000 or less in patients without medical comorbidities that may increase the risk of bleeding. So why? The issue of platelet transfusion is important, not only because of the cause of transfusion, but unnecessary platelet transfusion exposes the patient to the risk of sensitization and loss of value from subsequent transfusion owing to rapid platelet clearance, as well as the infectious and hypersensitivity risk inherent in any transfusion. So if it is not needed, more or less, we do not need to transfuse platelet immediately. Let's go to the second topic. So, chemotherapy-induced nausea and vomiting. So, this is nausea or vomiting induced by our anti-cancer agents. So let us discuss first the proposed pathophysiology of um, chemotherapy-induced breast cancer. So there are two primary mechanisms that have been suggested in the pathophysiology of the emetic response. So one is through the central pathway that includes the CTZ, or what we call the chemoreceptor trigger zone, an area located outside of the blood-brain barrier in the medulla oblongata. The other is through the peripheral pathway involving the vagal afferent nerves in the gastrointestinal tract. Various neurotransmitter receptors, including dopamine, 5-hydroxytryptamine, or 5-HT3, serotonin, neurokinin 1, and cholecystokinin, are activated by chemotherapy, causing an emetic response. So, the multiple pathways are thought to be responsible for the different types of chemotherapy-induced nausea and vomiting. Example, acute emesis, meaning nausea and vomiting that occurs in less than 24 hours after chemotherapy administration. It is usually mediated by the stimulation of your peripheral pathway, while delayed emesis, meaning after 24 hours post-administration, it usually comes from the stimulation of your central pathway. Okay, so what is the first type of CINV? So that is acute CINV. So it usually occurs within few minutes to several hours after drug administration and commonly resolves within the first 24 hours. So the intensity of acute onset emesis generally peaks after 5 to 6 hours. So the occurrence of acute emesis is increased in younger women, usually in those less than 50 years old, with low ethanol use, with history of motion sickness, and more or less history of previous nausea or vomiting. Okay, so for the delayed type of CINV, this usually occurs more than 24 hours after chemotherapy administration. It occurs commonly with the administration of the following drugs: is your platinum agents, um, cyclophosphamide, and or doxorubicin. Um, Specifically for cisplatin, emesis reaches its maximal intensity 48 to 72 hours after administration and can last for 6 to 7 days. We also have the third type, which is anticipatory CINV. And this occurs before patients receive the next chemotherapy treatment. So the difference as compared with the first two types would be it is primarily considered a conditioned response. So this is usually associated after a negative past experience with chemotherapy. So the incidence of anticipatory CINV ranges from 18% to 57%, and nausea is more common than vomiting. So younger patients may be more susceptible to anticipatory nausea and vomiting because they generally receive more aggressive chemotherapy and overall have poorer emesis control than older patients. So we also have breakthrough, meaning nausea and or vomiting that occurs despite prophylactic treatment and or requires rescue with antiemetic agents, meaning despite giving the adequate medications prior to the chemotherapy in preparation or in prevention of CINV, the patient will still have episodes in between wherein you need to more or less support it with other antiemetic agents. Refractory CINV. So this occurs during subsequent treatment cycles when antiemetic prophylaxis plus the rescue has not been effective. So refractory means the patient is unresponsive to the treatment given. Okay, after determining the more or less different types of CINV, the next step first is to determine the different chemotherapeutic agents and more or less the classification of these agents in terms of its emetogenic property. So we should more or less be familiar with this because this will be our basis later on what prophylactic medications should we give to those patients receiving this specific agent. So for those under highly emetogenic drugs, so it means more than 90% risk of experiencing CINV, you have the following drugs as mentioned on the left side of this slide. Moderately emetogenic drug, there is 30 to 90% risk. The drugs, check the drugs that was mentioned on the right side of this slide. So take note of some of the drugs that more or less similar. Take note of your cyclophosphamide. It is under highly emetogenic and also under moderately emetogenic. Why? So take note that if the cyclophosphamide dose given is more than 1,500 milligram per meter square, then it will fall under highly emetogenic. If the dose computed for cyclophosphamide is less than that dose or less than 1,500 milligram per meter squared, then it will only fall under moderately emetogenic. Why? In most solid tumors, the computation of your cyclophosphamide will just be around 750 to 1,000 milligram per meter square. So if that's how you computed the cyclophosphamide of the patient, then it will just fall under moderately emetogenic. Low risk. So 10 to 30% chance of experiencing CINV. That would be your 5-fluorouracils, taxanes, etoposide, bortezomib. So for minimal risk, meaning less than 10% chance of having CINV, please remember the following drugs mentioned in this slide. Okay, so after determining the more or less emetogenic property of the chemotherapeutic agents, so we now know what to give the patient. So for patients who will receive agents that will fall under high emetic risk, we have what we call the 4-drug combination. So first, we have the NK1 receptor antagonist, which will cover for your delayed CINV. We have the serotonin receptor antagonist, which will cover for your acute type of emesis. We have dexamethasone, steroids, and olanzapine. Okay. NK1 receptor antagonist. So remember that substance P is another neurotransmitter involved in the mediation of CINV. So the NK1 receptor antagonist blocks substance P from binding to its neurokinin receptors and play a pivotal role in the prevention of delayed CINV. So there are 3 drugs in this class: aprepitant, fosaprepitant, and your rolapitant. So aprepitant is an oral NK1 receptor. Okay. So for the continuation of aprepitant, so this is an oral NK1 receptor antagonist that crosses the blood-brain barrier and is usually given once a day for 3 to 4 days. Fosaprepitant is a prodrug of aprepitant and is given as a one-time IV dose. So the problem with aprepitant is that aprepitant inhibits CYP3A4 and induces CYP to C9 metabolic pathways. So this can lead to many drug-drug interactions like your oral contraceptives, warfarin, and dexamethasone. So for the second family, that would be your serotonin receptor antagonist. So serotonin is the primary neurotransmitter implicated in your acute CINV. So the 5-HT3 receptor antagonist blocks serotonin receptors in the chemoreceptor trigger zone and the gastrointestinal tract. So there are 4 medications classified as 5-HT3 antagonists on the market. So we have dolasetron, granisetron, ondansetron, and palonosetron. So palonosetron is often recommended by the guidelines due to the drug's higher binding affinity to 5-HT3 receptors and longer half-life compared with others in this class. So palonosetron is also the only 5-H3 antagonist available in a combination product with an NK1 antagonist, the netopitan. Okay, so for the next drug or the other agent, so we have our dexamethasone, which is a well-established antiemetic in patients receiving highly emetogenic cancer chemotherapy. Its antiemetic mechanism of action is not well understood, however, but one possible mechanism of action is that it may antagonize prostaglandin or release endorphins that may elevate mood, improve one's sense of well-being, and stimulate appetite. So for the fourth drug, we have olanzapine, which is an FDA-approved antipsychotic medication that blocks dopamine, serotonin, and histamine receptors. So there is a growing body of literature to support the use of olanzapine for the prevention and treatment of CINV, and it was also discussed, or it is also discussed within the clinical practice guidelines. So it can be used in combination with palonosetron and dexamethasone for the prevention of CINV in moderate and high emetogenic chemotherapies. Please take note of the last statement. So remember that separately, anthracycline falls under, let me go back, under moderately emetogenic, as well as your cyclophosphamide, as long as the dose is less than 1,500 milligram per meter square. But remember that if given together or if they are combined, automatically they will fall under high emetic risk. Please take note of that. Again, I already mentioned those drugs under 5-H3 antagonist and NK1 receptor antagonist. So let's proceed with moderate emetic risk. So for those who will be given drugs that falls under moderate emetic risk, we can use a 3-drug combination. Specifically, if you are going to give the patient carboplatin with a dose of AUC 4 milligram per ml or higher. AUC means under area under the curve. That's how we compute our carboplatin. So if you are going to give this one, the common dose of carboplatin, if given in every 21 days, is usually around AUC 5, 6, and 7. So definitely, if that's the dose, it will fall. You need to give the 3-drug combination: the NK1 receptor antagonist, the serotonin receptor antagonist, and your dexamethasone. For the other agents or for the rest of the agents under moderate emetic risk, then you can give 2-drug combination, serotonin receptor antagonist, and your dexamethasone. So, okay, so last statement. So remember, in cyclophosphamide, doxorubicin, oxaliplatin, and other agents known to cause delayed nausea and vomiting, offer dexamethasone until day 2 or 3. For those who will fall under low emetic risk, a single dose of 5-H3 receptor antagonist or single 8 milligram dose of dexamethasone will suffice. Cannabinoids, more or less, this is very recent, the medical marijuana, although at this point, evidence remains insufficient in terms of CINV. So let's give an example. So, for example, we have a breast cancer patient, stage 2B, who underwent definitive surgery, modified radical mastectomy. The patient was referred to a medical oncologist for adjuvant chemotherapy. So the plan for the patient is to receive chemotherapy for 8 cycles, for more or less 4 cycles of doxorubicin and cyclophosphamide, and 12 cycles of single-agent paclitaxel after that. So during the first 4 cycles, wherein the patient will be given doxorubicin and cyclophosphamide, what would be the prophylactic medications that you should give? And will it be the same if the patient already finished with your doxocyclo and will shift to your single-agent paclitaxel? So let's review. Again, doxorubicin and cyclophosphamide. So they are moderate, they will fall under moderately emetogenic per agent. But when combined, again, will fall under high emetic risk. So in this case, you will give the patient the 4-drug combination that was discussed. Your NK1 receptor, 5-H3 receptor antagonist, dexamethasone, and olanzapine. For the paclitaxel, single agent under low emetogenic risk, a single dose of 5-H3 receptor antagonist, or a single dose of 8 milligram dexamethasone will suffice. Okay, so for the next problem, we have diarrhea. So amongst the chemotherapy agents, remember that 5-FU infusions and irinotecan are the agents that commonly causes diarrhea. So it can be immediate or delayed 48 to 72 hours post-infusion. So how do we manage these cases? Hydrate the patient, check for the electrolytes, sodium, potassium chloride, and do electrolyte correction if needed. Administration of anti-motility treatment is very important. So for the first occurrence of diarrhea, you should immediately instruct the patient to take 2 tablets of loperamide, because loperamide preparation is 2 milligram per tablet. So instruct the patient to take 2 tablets immediately, and then 2 milligram, 1 tablet every 2 hours, um, while still with loose stools. So, but just take note that the patient cannot exceed a total daily dose of 16 milligrams of loperamide. Example, in patients who will not respond with your loperamide, the next option would be octreotide, which is given more or less via injection. This is a somatostatin analog. So this is our second line if the patient will not respond to loperamide. Okay. And opiate-based preparations, because as you can remember, opioids usually causes constipation. That is one of its common side effects. Okay, so everything that we have discussed previously, that would be under side effects of your chemotherapy agents. But of course, we also have our targeted agents from EGFR, directed small molecules. Example will be erlotinib, afatinib, lapatinib. Your antibodies, remember MAB at the end, so monoclonal antibody. Your mTOR antagonist. For this specific molecules, it will be discussed further under the specific type of cancer wherein it is being used. For example, you will encounter EGFR small molecules under lung cancer, for the antibodies under colon cancer, mTOR under your breast cancer. So in this slide, we are just generally discussing what are the side effects of this particular molecules. Sometimes there is a misconception that only chemotherapy are toxic, but remember that your targeted therapy are equally or sometimes even more toxic than your chemotherapy regimens. So for this type of molecules, acneiform rash is very common. So commonly in the face, in the scalp. So supportive treatment. So topical medications, low potency corticosteroid creams, and if really needed, you can of course refer the patient to a dermatologist for co-management. Again, remember, cancer will always be a multidisciplinary approach. So second common side effects of these molecules would be diarrhea. Same with the management of diarrhea secondary to some chemotherapy agents. We just give loperamide or stool bulking agents. So again, supportive care. And actually adequate adjustment of the medication if needed, depending on the severity of the side effects. Next would be the anti-VEGF directed treatments, so vascular endothelial growth factor receptor. So very common example would be your bevacizumab. So second one would be your multi-kinase inhibitors such as sorafenib, sunitinib, and pazopanib. Again, you will encounter bevacizumab, especially in colon cancer. For your multi-kinase inhibitors, you can encounter the three as treatment for your liver cancer and kidney cancer. So for these two types of molecules, hypertension is one of the common side effects. So again, supportive management. If the patient is already hypertensive, even before the treatment, before starting this molecule, the hypertension should be controlled. So if you need a referral to a cardiologist and so on to control the BP, it's very important that it is controlled prior to the administration of these molecules. So during treatment for a patient who is non-hypertensive, just maintain the maintenance medication for hypertension, adjust accordingly depending on the BP monitoring of the patient. Second, common side effect is proteinuria, which can be reflected in the patient's urinalysis. That's why we always do baseline urinalysis prior to every infusion of bevacizumab. So for the presence of proteinuria, we should assess carefully if more or less how severe it is or if there is a need for adjustment or discontinuation of the drug. Okay, thyroid function or thyroid hormones are usually also deranged or affected if you are giving your patients multi-kinase inhibitors such as your sorafenib and pazopanib. So part of the monitoring while we are giving these drugs is periodic surveillance of your TSH and tyrosine and your thyroxine or FT4 levels. And again, if there will be some abnormalities found, number one, refer accordingly, refer for co-management with our endocrinologists, adjust the medication or hold the medication depending on the indication or severity of the result. Other side effects that you should watch out for would be gastrointestinal perforation, arterial thrombosis, hemorrhage. We also have palmar plantar dysesthesia or the hand and foot syndrome. So it can be seen usually after the administration of these agents. Sometimes even with chemotherapeutic agents such as gemcitabine and your liposomal doxorubicin. So depending again on the severity of the hand and foot syndrome, we should assess if, well, number one, provide supportive care, topical emollients, moisturizers, analgesics, hydrate well. If still not responsive, then consider dose reduction of the drug. So this is an example of your hand and foot syndrome. Okay, so protein kinase antagonist. So again, for imatinib, dasatinib, sorafenib, pazopanib, we should watch out for hepatic and cardiac toxicities. So when you're giving these drugs, again, you always monitor for the liver function test. Check for ECG if with indication, and do regular monitoring of your 2D echo with Doppler as well. So existence of prior cardiac dysfunction is a relative contraindication to the use of certain targeted therapies such as trastuzumab. So remember that trastuzumab is usually given in breast cancer patients with HER2 new positive breast panel result. So it is under the guidelines that you need to do a baseline 2D echo with Doppler first to check if the heart is good, if the ejection fraction is good before the administration of this specific drug. And even if the baseline 2D echo is normal, while giving trastuzumab, you will still continue to monitor 2D echo every 3 months until the end of the treatment. And if there are abnormalities, so for example, to be specific with trastuzumab, we are looking for the ejection fraction. If the ejection fraction will have a decrease of 10% or more from the baseline ejection fraction prior to treatment, that is an indication to hold the drug temporarily until the ejection fraction improves again. Or if the result of the 2D echo will show an ejection fraction of less than 49%, so definitely you need to hold the medication and wait for the ejection fraction again to recover first, and of course to refer also with the appropriate subspecialty for co-management. Okay, immunotherapy. So for your immunotherapy, there are a lot of side effects that should be considered, but we have what we call the common side effects, and we have those which will fall under severe side effects. So for the common side effects, more or less, I think I should more or less call your attention with hypopituitarism, hypothyroidism, um, flu-like symptoms. Why? Um, okay. Before I explain that, more or less, I will also flash first some of the severe side effects that can be expected: colitis, hepatitis, pneumonitis, myocarditis, and so on. Why? Immunotherapy causes these side effects, many of which happen when the immune system that has been revved up or activated to act against the cancer also acts against healthy cells and tissues in the body. So different people will have different side effects, and more or less strict monitoring of this one so that you will be able to see if you need adjustment, if you need referrals to other subspecialties to manage the following, you should do so. Okay, so other problems that we may encounter. In stage 4 patients, we do encounter effusions. We do encounter pleural effusion. We do encounter more or less fluid in the lungs or fluid in the abdomen. So let's go first with pleural effusion. So the most common, if the patient already have the presence of effusion, it means that the patient is already in the advanced stage. So lung cancer, breast cancer, and lymphomas account for 75% of malignant pleural effusion. And by Light's criteria, the characteristic of pleural effusion secondary to malignancy is exudative. So just to more or less, for you to remember the criteria of exudative, so these are the following. Okay, pleural effusion. Going back again to the first half of the discussion, I remember that um, for us to be able to confirm cancer or for us to be able to diagnose cancer, we need to have a biopsy. So we need to get a specimen for testing. So sometimes it's easier because there are visible tumors outside, meaning uh, more or less visible uh, with the naked eye. So in those cases, that is what we call accessible lesions. It would be very easy for our colleagues to get a sample of that for biopsy. But sometimes some patients will not present any outside tumors, and more or less some of them will have tumors inside the body, lung mass, colon mass, pancreatic mass, and so on, wherein we need a different way to get a sample. And as was discussed on the first half, we can usually do image-guided biopsy of that lesion. Sometimes, if you don't have any specimen or the tumor inside the body is not accessible by image-guided biopsy, sometimes effusion can be used as specimen for biopsy. But always remember that it more or less, it is very low yield. So the chance of having a positive malignant cells from effusion is very low. So if the specimen that you used for biopsy is from the pleural effusion or if pleural fluid, a negative result or negative for malignant cell result doesn't mean that we are sure that it is not malignancy because it is very low yield. So again, based on what was discussed previously, it is better to get a specimen from other sources. Okay. If the patient have pleural effusion and symptomatic, meaning patient have difficulty of breathing, easy fatigability, cough, then thoracentesis is usually performed first during the first occurrence or diagnosis of pleural effusion. But if after the thoracentesis, the effusion keeps coming back, or for example, we are still waiting for other results to come before we can treat the patient, it is more ideal to put a chest tube drainage, either a pigtail insertion wherein it will continuously drain the fluid. So again, one indication, if after thoracentesis the symptoms recur within 2 weeks or earlier, we should proceed with pigtail insertion. We usually even encounter patients with recurring pleural effusion even after 2 days only after thoracentesis. So if the patient is already on pigtail or chest tube, so fluid is aspirated until the flow is less than 100 ml in 24 hours. Once the output is already low, then you can consider pleural disease wherein you can already remove the drainage. This is usually done by our surgery colleagues. Okay, another fluid that can be secondary to malignancy would be pericardial infusion. So in these patients, you need to more or less remove that fluid for the patient's condition to improve. So you need to more or less refer to our cardio colleagues for a possible pericardial window. Okay, so if the patient's condition does not permit surgical procedure, then sclerosis can be attempted with doxycycline and or bleomycin. So another problem would be fluid in the abdomen or ascites. So malignant ascites can be managed by paracentesis or removal again of fluid. And if it is recurring very frequently, you can also offer pigtail insertion for the fluid to just continuously drain rather than doing paracentesis repeatedly. Um, Of course, for pleural effusion, pericardial infusion, malignant ascites, the following procedures mentioned are just supportive. Meaning, at the end of the day, you need to treat the underlying cause for us to be able to control that fluid. So, for malignant ascites, if the underlying malignancy is unresponsive to the therapy or to the systemic therapy, then another option is the peritoneovenous shunts, which may be inserted as well. So again, these are just supportive treatment. We still need to treat the underlying cause for adequate control. And once the malignancy and the effusion is already controlled, then you can remove the tube as well. Okay, so another concern for our cancer patients would be nutrition. Um, there are several causes which may be the cause of more or less malnutrition or for a cancer patient to be poorly nourished. Some because of the tumor itself, especially in patients with cancer of the liver or metastasis to the liver, they will usually feel bloated or they will feel that easy fullness complaint, and more or less they won't be able to really eat well. Another more or less example would be those with poor performance status, those patients who are really in pain, um, especially if the pain is not controlled, then that's another reason why the patient usually loses appetite. So objective assessment have included the use of a prognostic nutritional index based on albumin levels, which can be checked via blood extraction, triceps skin fold thickness by physical examination, transferrin levels, delayed type of hypersensitivity skin testing. Um, we also have simpler approach to define the threshold for nutritional intervention, meaning who are the patients who are in more or less real need for nutritional intervention and referral as well to our nutritionists, those who have 10% unexplained body weight loss, those with serum transferrin level less than 1,500 milligram per DL, and those with serum albumin less than 34 grams per liter. Okay, so cancer therapy is substantially more toxic and less effective in the face of malnutrition. So it is very important for the patient to be well nourished during the treatment because it will lessen the problem of both the doctor and the patient. So enteral nutrition is still the best, meaning nutrition more or less provided orally or via tube feeding or specifically via NGT or nasogastric tube or PEG insertion. It is still better than parenteral supplementation. Parenteral supplementation example would be our TPN, um, the white one, which is usually infused for 24 to 48 hours, Nutriflex, and other brands. So that is an example of your parenteral supplementation. But at the end of the day, it will not beat more or less what enteral nutrition can provide to the patient's body. So one agent, megestrol acetate, it is a progestational agent that has been advocated as a pharmacologic intervention to improve nutritional status. So we can give these drugs to patients who are in really need for a nutritional intervention. Psychosocial needs of patients vary with their situation. So they also need psychosocial support. I think I mentioned that in my introduction, support from the family, community, and so on. So more or less, patients undergoing treatment experience fear, anxiety, depression. Self-image is often seriously compromised. Best example, in patients receiving chemotherapy that causes alopecia, especially in women, of course, that would be a contributory factor to a possible anxiety or depression as well. So if the patient is continuously losing weight, it's another example of more or less a problem in terms of self-image that would make them more depressed. So loss of control over how one spends time can contribute also to the sense of vulnerability if more or less they are compromised by other factors like pain, um, effects secondary to RT or surgery that may limit the function. Sexual dysfunction as well is highly prevalent depending on the agent given. So more or less we should address all aspects, not only the medical side but also the psychosocial status of the patient. Okay. Patients may experience difficulty re-entering their normal past life. Perhaps the most pervasive and threatening concern is the ever-present fear of relapse. So this is very true. We usually encounter this, for example, in an early stage breast cancer patient who already finished surgery, chemotherapy, radiation, and endocrine therapy. Even though the patient already finished the complete treatment, on follow-up for surveillance, there is still this more or less concern or paranoia of always thinking, did my cancer return? Sometimes any symptom that the patient may feel, they correlate it with, is it because of my cancer recurring, and so on. So an empathetic healthcare team should be sensitive to the individual patient's needs. So death and dying. So especially in patients who more or less have an advanced stage. So um, the path of unsuccessful cancer treatment usually occurs in three phases. Optimism at the hope of cure. For example, you receive the patient at an early stage, you have given the required multidisciplinary treatment, and then the patient is already on surveillance. However, after a few years, the patient recurred. But this time, the goal for therapy is not the same as before. Before, it is for curative intent, but since it recurred, more or less the intent this time is just for palliative therapy, meaning the chance of the cancer more or less being eradicated completely is very low. The only goal at this point is just to control the spread, control the size, limit the side effects secondary to tumor, and to improve the quality of life of the patient. But after that, more or less everything will end at the disclosure of imminent death. So in this slide, we also show the stages of adjustment to the diagnosis from denial, isolation, anger, bargaining, depression, acceptance, and hope. So for those patient who are dying, it is very important to more or less disclose it honestly with the patient and uh, the family. Always remember that if the patient is conscious and can think for himself or herself, the patient has the right to know everything, even more or less the information of dying, the patient has the right to know that, um, including the family as well. So more or less, um, just explain everything um, and emphasize with them that you will be there for them until the end. More or less, you are there to give supportive care the best that you can so that the patient can more or less live comfortably as much as we can until his or her dying um, days. For the physician's side, taking care of cancer patients, we also have what we call burnout syndrome. So characterized by fatigue, disengagement from patient and colleagues, and loss of self-fulfillment. So we need to balance also. So if this syndrome is beginning to more or less uh, beginning to show, uh, you should more or less intervene as soon as possible by more or less doing stress reduction, maintaining balanced life, and more or less setting realistic goal for your patient. Meaning, as a doctor, you should also know more or less the limitations of uh, the things that you can do for the patient. End of life decisions. So, vigorous and invasive medical support for a reversible disease or treatment complication is assumed to be justified. If the reversibility of the condition is in doubt, the patient's wishes determine the level of medical care. So these wishes should be elicited before the terminal phase of the illness and reviewed periodically. Um, we should more or less explain to the patient ahead if we think the course of illness is going from more or less manageable, or if going towards the patient dying already. Because prior to the terminal phase, you should already discuss, you should already ask, or the family should already ask for the patient's wishes, because it is different for different individuals or patients as well. For example, before entering the terminal phase, you should already prepare the patient and family. You should already ask if the patient more or less felt this kind of pain, how much pain medications will you allow, expecting these concurrent side effects. And more or less at the same time, in terms of resuscitation, the as we all know, we have the do not resuscitate, do not intubate, more or less for some patients, wherein if the patient more or less is going down, um, some, or ideally, if it is a cancer patient, they already should have a decision. The patient already should have a decision with the family members on what the patient wants. For example, if the patient's heart stopped, or if there's hypotension and so on going down, um, it should already be clear by paper. For example, the patient may already tell you, please, if this happens, I don't want to be intubated anymore. I don't want to be hooked in a mechanical ventilator anymore. So the earlier, more or less, the patient prepared for this one, the better, for the more or less peace also of the entire family. So that would be the last slide. So that's the end of our discussion, part 2 of the principles of cancer treatment, management of disease, and treatment complications. Thank you.